Good afternoon, ladies and gentlemen. I thank the ISNCon for this opportunity to present the data, the survival data of 35,000 hemodialysis patients over a period of 15 years at Apex Kidney Care. I am going to divide my talk into the why, the how, the what, and the insights that we gained by this analysis. 80% of our renal replacement therapy patients are dialysis patients and only 20% are transplants. But on which patient do we focus on more? Whose calls do we take on priority? Whose notes do we write in more detail? I think this is anybody's guess. There is something known as the Pareto principle, which says that as physicians, 80% of our efforts are focused to 20% of our patients. And why is this so? Because complexity is sexy and simplicity is mundane. So I asked myself this question: how many long-term hemodialysis survival studies have been published from this country? And when I looked up the literature, I found that the Pareto principle was alive and kicking. Now let's get going. This is the survival analysis of 34,363 patients who received maintenance hemodialysis in 238 centers across 13 states of the country over 15 years from 2008 to 2023. These are all patients who were receiving dialysis at Apex Kidney Care centers, and all their data has been painstakingly recorded in the proprietary electronic health records called Access. In AKC, we take data gathering very seriously, and we have a 5-tier data collection team which is headed by a nephrologist who is the QA head. We have a tier of dialysis physicians, followed by quality assurance leads, followed by quality assurance single point of contacts, to whom the chief technicians of every center report to. There is a responsibility for data gathering at each level of this hierarchy, and this combined effort goes to develop the entire database in Access. The process of data gathering has evolved over these past 15 years, and when I look back, the data gathering process 15 years ago is clearly not as deep, as wide and as robust as it is today. We used death and dialysis discontinuation as an event, and we censored patients when there was evidence of recovery from AKI, a transplant, a switch to PD, a transfer to some other center, and all those patients whose data was not available and were lost to follow-up. So these were the findings. There has been an incremental increase in the number of incident dialysis patients year on year, and the current year of 2023 would have about 12,000 patients enrolled by the end of that financial year. I need to spend some time to explain to you the initial hit phenomenon. If you see any hemodialysis registry across the world, be it the USRDS or the ANZ or the ERA, a patient gets enrolled in the registry only after they complete 90 days of existence on maintenance hemodialysis. The reason for that is that a large proportion of patients get dropped off in these first 90 days for reasons of death or a variety of other reasons. In our case too, we started off with 34,363 patients who by the 90th day declined to 18,033 patients. Of this, 16,000 patients who were lost in the first 19 days, a proportion of them were AKIs who recovered. I would think it was about 200 patients. A very small percentage switched to PD. About 500 patients got transplanted. Many got transferred. About 24% died. Some discontinued dialysis, and about 30% of patients' data was not available. So the analysis from our study focuses on all those 18,000 patients who survived the first 90 days of dialysis. Their median age was about 55, a third were females, diabetics constituted 20%, 61% were taking dialysis in private centers, and the median frequency of dialysis was twice a week. As I mentioned earlier, 24% of patients died, a very small percentage discontinued dialysis. AKI recoveries were to the tune of about 200 patients. There were about 500 transplants. a very small proportion switched to peritoneal dialysis, 15% of the patient got transferred to other centers, and in 30% of the patients data was not available. And therefore, like the USRDS, all those patients who survived the first 90 days were the subjects for this analysis. We analyzed patients by their etiology of CKD, and what we find that the distribution of hypertension as a cause of CKD or diabetes as the cause of CKD is fairly consistent with data from other registries. However, I would like to bring to focus this group. We had 10 patients who were kidney donors, which raises the importance of evaluating our kidney donors very carefully. Let's now look at our survival data. Patient survival at the end of 5 years was 62%. Let's compare this with the USRDS. Now, these two data sets are different on several fronts. The USRDS data, the mean patient age is at least 10 years more than our patients. There was a larger proportion of diabetics in that data set. Also, these were incident figures as compared to prevalent figures in our data set. We looked at the gender differences in patient survival in our data set, and we found that the male and the female survival was more or less the same at 62%, which made us happy. However, if you look at the general population in India, the mortality for females is about 175 per 1000 females as compared to 250 per 1000 males, which means in the general population, the females survive better than males. However, this survival advantage somehow gets lost in the dialysis population, and this is the same thing which plays out in data from other registries as well. So, which raises the question, are women being adequately represented for renal replacement therapy? Wikipedia tells us that the distribution of males and females in this country is more or less the same. The C cohort tells us that females form 39% of the CKD population. Our data tells us that women form 33% of the hemodialysis population, and a recently published article tells us that women form only 20% of our living donor transplant recipients. This tells us that women are not adequately represented in renal replacement therapy. 15% of women with CKD don't get dialyzed, and 49% of women with CKD don't ever get transplanted. Let's now look at age as a factor which influences patient survival. Clearly, age is not just a number. It comes with a mortality risk. Patients above the age of 65 have a 54% 5-year survival as against 71% for those below 45 years of age. We then looked at diabetes as a risk factor which influences survival, and clearly the diabetics did not fare as well as the non-diabetics. We were very interested to see the survival in those patients who were being dialyzed in public centers as against the private centers. And as it turns out, there is a significant difference in survival, with those patients being dialyzed in the private centers having a significantly higher survival rates than those being dialyzed in the public centers. The point that we were most interested to see in our data set was to study the effect of hemodialysis frequency on patient survival. And I think the graphs speak for themselves. Clearly, patients who get dialyzed adequately have a far superior survival than patients who are not. We then looked at survivals at the end of 1 year based on dialysis frequency. And as you can see from this slide, clearly patients who were on adequate dialysis fared far better than those who were on inadequate dialysis. I would like to raise the issue of residual renal function here. This concept of RRF is a Western concept where patients get their AV fistulas made when their creatinines are 2.5 and dialysis gets initiated when their creatinines are 4.5. As against our country where patients initiate dialysis anywhere between a creatinine of 7 to 15. Are these two populations similar? Can concepts of residual renal function which are relevant to the Western population or the Western data set be adopted lock, stock and barrel into our patients? This image clearly says that the concept of residual renal function is perhaps not relevant to our population and therefore an error if we adopt it. We then looked at mortality. In our country, most of the deaths were for cardiovascular reasons and about a quarter of them were because of infections. We lost about 350 patients due to COVID and CRBSI formed 2% of our mortality. I would also like to bring to your attention certain specific mortality causes. IC hemorrhage at 4%, hyperkalemia at 1%, pulmonary edema at 16% and accelerated hypertension at 2%, cumulatively adding up to about a quarter of all the mortalities, probably has something to do with the interval between two dialysis sessions and the importance of dialysis adequacy. I also want to highlight to you that we had 10 patients on hemodialysis who committed suicide. So what really matters in long-term survival of our hemodialysis patients? Clearly, age is a factor, diabetic status is a factor. But if there is one singular modifiable risk factor which influences hemodialysis survival, it's dialysis frequency. Hemodialysis frequency matters when we are talking about patient survival. Let me now summarize. Women are underrepresented in our renal replacement therapies. The concept of residual renal function seems unsubstantiated. If there is any factor that influences long-term survival, it is frequency and adequacy of dialysis. And lastly, we need to spend more time taking care of our hemodialysis patients. I close here and I take this opportunity to thank my colleagues at Apex Kidney Care, our friends at IIT Bombay and the governments of Delhi, Goa, MP and Telangana. I thank you for your time.